Good morning, everybody. Thank you, Valérie, for this kind invitation. So I will start with this talk and trying to say nothing to disclose. And you may expect me to bring evidence on a subject that we discussed yesterday about the timing in the preemptive, and I don't have evidence. What I will bring is a few observation, case report, and bring hypothesis or some substract for thought that maybe you will consider in the future when you are working with children. I think that's the way we are building evidence, as we said yesterday, just exchanging information and new things, case report like the nice case with hepatoblastoma that were treated with resection and closure of the shunt. So I think that's what we need at the moment to build our evidence. My talk will be essentially oriented to speak about the extrahepatic congenital shunt, those who have very large flow, large shunt, so a high ratio of porto-systemic shunting, and usually not very much going into the liver. About the timing, I will consider more going through preemptive, so the talk will be oriented to searching elements for justifying preemptive treatment. For me, the late timing is patient with complication, and we've seen many the last 2 days. Early is patient having symptoms like learning disabilities or hyperammonemia, but no major complication like we have seen. And the preemptive would be attacking the subject of the subclinical condition and prophylactic closure of the shunt. Management will be oriented on some ideas or perspective to be curative. Curative meaning closing the shunt, stopping the portosystemic shunting, and flowing the portal blood into the liver. That's the real cure. And in my view, palliative treatment are either transplant or simply wait and see. Wait and see is a palliative treatment because we just observe, and we should just categorize it like that. And also when we do the closure with persisting chronic portal hypertension, I think we are creating a new condition. It is a cure of the shunt, but it's not curing the child and bringing the child into a physiological condition, because we bring the child into a condition which is chronic portal hypertension, which needs follow-up. That's not exactly a cure. So I would put palliative, but I will not address that today. So the dilemma was to know if we try to go too early, which is asymptomatic children, or if we wait for complication, and we agree that we should not wait for complication. It's too late. It is very difficult to know where to set. Too early, is it really too early? I would say that what's important to discuss today is how much too early we have to do it. Too early is never too early, because the shunt is an abnormal communication, it's a malformation, it's a pathological condition, and we would not accept similar malformation in other parts of the body. We would treat them. The problem is that in the asymptomatic, I would quote Nageliton, who said this morning, they are asymptomatic because we don't find the real pathology. And it's very difficult to know in a child less than 3 years of age what type of neurological problem is accumulating. It's very asymptomatic, but in fact they are. We just don't have the tools to diagnose it. So I will try to bring a little bit of information, at least what I have today. Remember that wait-and-see strategy, and we have been discussing yesterday and today about that, is a risk of developing liver malignancies, of having pulmonary hypertension that is not amenable to treatment. And then there are the cognitive retardation and the learning disabilities that we have really trouble to estimate, and that we see usually too late. So we diagnose the patient when it's already done. Last, from a radiological and surgical point of view, the fact that the shunt is growing with the child is inducing really a problem, which is in the liver, the veins are not growing, the shunt is growing, the flow is more important. So if you look in the proportion between flow on one side, flow on the other side, there is also an argument to say it's easier to change the flows, to regulate them, to close the shunt when they are younger rather than when they are older. And there is this hypothesis that Stephanie, and I will come back on that later, brought yesterday, is that there is an involution of the portal system in the liver when the portal flow is low because the shunt is too active. And I will bring more information about that. About this dilemma of knowing if we should do it very early or not, I remember that 10 years ago, the group of Stephanie again was proposing this algorithm, and we are following more or less that. And in this algorithm, the criteria was 2 years for the intrahepatic shunt, and we tended to apply that to every shunt. So not many shunts were proposed for treatment before the age of 2 because we had the idea we should wait spontaneous closure. Fortunately, things have been moving, changing, and this is the new algorithm we said. I suppose it's correct because I built it from your talk yesterday, where we have been moving slowly to younger people. Now the main age, the reference is 1. This is valid for ductus venosus, the age type shunt of the intrahepatic, where by the age of 1, if they are not closed, you should give an opportunity to close. If by the age of 1 they are not closed, then you may act. And then Stephanie introduced this idea that in the extrahepatic Abernethy 1 shunt, for example, or Abernethy 2 with a larger shunt, a neonatal cure could be proposed if the umbilical vein is still open. And for any other extrahepatic shunt, the age would be at the time of diagnosis. So we are moving towards younger patients. Maybe not everybody, but that's the message I've kept from yesterday. I come with some clinical observation, maybe lessons to learn in the future, and start with the fact that we may be underestimating the effect of the large shunt, the major porto-systemic shunting, especially in the small children, because we cannot assess them. So this is a case, a child with 7 years at the time we met him, it's an Abernethy, and he had an episode of encephalopathy at the time of a gastroenteritis. And he was brought to us. He had learning disabilities. He was really slow at school. He had some retardation. And he also had some minor intrahepatic portal venous radical, but at the biopsy, a severe fibrosis and pseudo-nodular liver. You can see that the liver tests are slightly altered. So what we did in that child is that we transplanted the child. Now I bring this child, not for the treatment of with the transplant, but because he was the first we entered in a study done by our neuroradiologists, which is studying the connectome. They are studying on a functional resonance, which is done without sedation, without contrast, so it's relatively simple to do. And they are studying the connection between area, networks in the brain, which is done by computing. I mean, take 18, 20 hours of computing of the data of the MRI. And they study the metabolic activity, the oxygen consumption, and they establish the connection and the working networks in the brain. You see, okay, that looks nice, but it doesn't seem to be very active, this brain. And in fact, if we look the difference between the pre-transplant and 1 month only after the transplant, you can see that things have been changing quite a lot. There is more activity, and there is the network are more, but they are also more active. Now, this child I presented because we did a study. I did the transplant more than 2 years ago. He came back after 1 year, and we repeated that, but they use a new software, which is even more complex, bringing 32 networks in the brain. This is the result. You can see that in this, the pre and the post are accumulated in one image. In blue, you have the connection that were active, and a month after are not really more active. In red, what is been changing? It's added or it's more active. You see 1 month after, on this more complex image, there is a difference, but it's not that much. So after 1 month, the child was clinically much better, starting being more active, sleeping less, doing things that he was not doing before. And we were happy clinically. But this is good. But when we did the 1 year control, that was really a big change. So it took 1 year to have this brain awakening, working better. In red is everything that is more active or that is new. And you can see the big difference between the two pictures. Pre, 1 month and 1 year. Well, I think we are not understanding exactly what is in the brain and what corresponds to encephalopathy. Encephalopathy is probably the last stage of the damage they have in their brain, and we should be able in the future to study a little bit more. It's very difficult to do neurocognitive tests in very small children, but what we know is that small children are having, during the first year of their life, their most important time for the brain development. I found that in the literature, and you can see that cortical gray matter is expanding very much during the first 2 years of life. The white matter myelination is also developing very much during the first 2 years of the life. We cannot assess them. And our limit is to treat the patient with shunts when they are going to 1 or 2 years, which means they already have been accumulating a lot of problems that we never know, because only the patient will be an expression of what he could have been if you treat him very, very early. If you treat the patient at 2 and he improves, maybe it could have been much better if the treatment was offered much earlier. And last, high order functional network, which is what we are trying to provide and keep active, is also very importantly developed during the first 2 years of life. So I would say that if you look on all of that, the result from the neuroactivity is preliminary, it's not yet published, but we are working on it. Interestingly, we found exactly the same network activity in patients with cavernoma. They have portal hypertension shunting, and they have the same difference before and after the mesorex. The mesorex is just resetting their brain exactly the same way that compared to what happened when you close a portosystemic, congenital portosystemic shunt. I would say that this is food for thinking about doing the closure earlier, possibly much earlier. As early as possible is probably the way we should go, might be better. Other observation about Abernethy type 1. This is a child who came and had hyperammonemia. It was very small, 4 months of age, diagnosed because he had ammonium quite high, and had also a trisomy 8. He had, as you see on the picture, type 1 Abernethy. And the funny thing is that on the ultrasound Doppler, for a 4 months of age, they found on the ultrasound, they could see the Rex recesses. And in that Rex recesses, there was some flow. So they wrote to me, and I asked them to do a portogram, a retrograde portogram, and you see nearly all the branches in the liver. And the bigger part is the Rex recesses, which was a part of the umbilical vein. So the question was to see what we can do with that. And I said, I think we should try to close the shunt, but do a mesorex, of course. And when he came, it took 3 or 4 months because he was from far away, because he was small, because we had to organize. And when he came, the first thing that I noted is that although the liver biopsy is normal, is that when we did the ultrasound, we could see the Rex, and there was 0 flow. So I was not that happy, explained to the parents that we have to try because that's a good opportunity. And at the end of the mesorex, I had no flow. Sorry for the picture. I don't know what happened in the operating room. That's the best I found. So I did the shunt. I redid the shunt. There was no flow. I did a phlebography. I could see some branches in the liver, but you see that there is like a lake. It's not passing through the liver. You know, I'm good at obtaining flow in my mesorex. So really, I tried 3 times, and then I abandoned. 0 flow, failure, complete failure. And then I get another child with also a trisomy 8, and I can say that I know a third one which is not operated, and I've seen that in some series there are other trisomy 8. If somebody is interested, this is something to search because it is not yet associated to CPSS, and I can tell you that for sure trisomy 8 is associated. Part of the pattern of a trisomy 8 is probably having a trend for CPSS. So this child was diagnosed at 6 years of age because she bled from esophageal varices, and she had some ascites because she somewhat decompensated the liver. She also had a splenomegaly. And what was found is that she has an Abernethy 1 with a stricture at the level of the communication. You can see nicely that the shunt going to the cava and to the atrium, and you can see there is a narrowing on the CT scan on the right. You can see the narrowing. Because of this narrowing, she had portal hypertension, and because she had portal hypertension, she developed a cavernoma. So you can see the cavernoma there. This is a late picture in the middle. You can see that there is a cavernoma, and we can see some branches in the liver, which means this cavernoma is flowing slowly but surely to the liver. You can see image of the cavernoma on the other picture. And by the way, she also had a very nice autogram in tripatic. So although, even if I missed my first one, I said, this one I will try as well. And I did, and it worked. So I did a mesorex in Abernethy 1 because the liver had a very nice portogram, because usually you don't find that. And the mesorex functioned very well. Now the child is nearly 2 years after the mesorex. Perfect. No problem with the shunt, no problem with the porto-systemic shunt, and no problem with the mesorex as well. So this one confirmed that it is possible, but I did not publish because I wanted follow-up, but because it is a very strange situation that probably we will not find, I will not find again. But then I thought, after the talk, before the talk, and I modified my presentation a little bit after the talk of Stephanie, but I had the same idea. What if the intrahepatic portal system is present in utero and at birth, but vanish later in absence of flow? So what can we find about that? Remember what Stephanie said yesterday? The umbilical intrahepatic portal system is one thing, but the porto-systemic, the congenital porto-systemic shunts, they usually arrive from the malformation of the extrahepatic portal system. I speak about the extrahepatic shunt, remember. So what if the umbilical vein, when it's normal, is feeding the liver, is creating an intrahepatic portal system, and something goes wrong after? So this is the normal situation in a fetus. You have the portal vein feeding at low flow because the gut is not functioning, and we have an umbilical vein, very high flow, entering the liver and perfusing the liver. Because I discovered recently that the Arrange's canal is smaller than the umbilical vein. So it flows to the heart, but a part of the blood from the umbilical vein is going to the right, perfuse the liver, and goes, goes into the heart. So this network intrahepatic exists. What happened at birth is that the umbilical ligament stopped, closed, and the portal vein is flowing. So what Stephanie proposed yesterday, I changed a little bit that picture because my first picture had no portal vein, is that in utero, the umbilical flow goes into the liver, and part of it is diverted into the malformation, which is the congenital portosystemic shunt here under, and at the in utero, because maybe it's also in utero, the portal vein flows retrograde but disappears. Or this happens after birth, we don't know. We should study that because it's very interesting. This is the situation in utero, and after birth, umbilical flow disappears, portal vein disappears progressively, and so you have the passage from Abernethy type 2 into 1. If this is the correct hypothesis, that's very interesting because at birth, after the closure of the portal vein and the umbilical ligament, you may have a period, and that's what this is shown by the two examples I brought you, where there is an intrahepatic portal system without flow, a little bit of flow, or nearly no flow, and the Abernethy functioning in extrahepatic position. So what I did is that I pulled back my Abernethy 1 where I did not close the shunt because the pressure was too high and I didn't want to push them into portal hypertension. And I did a retrograde portogram. You see nothing. The intrahepatic portal system has disappeared. So it seems that possibly within the first months of life, the veins are still okay with some flow and progressively disappear. And then we have this French case, 6 years of age, where I could do the mesorex. And probably because of the portal hypertension, it created a cavernoma. The cavernoma brought some flow in the liver. And this is like a patient with a normal cavernoma. The small flow brought by the cavernoma in the liver protected the portal system. And that's why I could just do a mesorex in that child when every other child has no portal vein in the liver. That's quite funny. In conclusion, what we need is more information from the obstetrician. we need them to analyze the intrahepatic portal system, the umbilical vein flow, the portal vein anatomy and the flow. And this is something I found in literature recently. There are some people who are really good at looking at that, and they search, and their research brings that X, which is a very typical aspect during the prenatal ultrasound. In the X, you find the umbilical vein, you find the portal vein, and you find the right portal system. And this is the X. And they say this is a very typical thing you can do. And that should be part of the standard examination of the prenatal screening. Because then we will understand if we have that in every child, when a diagnosis of congenital porto-systemic shunt is done, we could go back to the obstetrician and say, can you show me the picture? Because if it is true that the portal system exists and then disappears completely within a year or two after birth, then we know that we must find a way, and I share the opinion of Stephanie, when you can do it at birth, through the neonatal, through the umbilical vein, that would be so nice. To do that, we need the prenatal diagnosis, so we need to expand our meeting and bring more obstetricians and more radiologists to do the prenatal screening. The second is that I think that we have many reasons to propose as early as possible. I know it's a dilemma. I know not everybody is happy to do it, but I think there are many, many reasons to do it because we don't have the tools to follow carefully the brain of the children less than 2 years of age, and we should take the principle of caution that we should prevent something happening to their brain because it may be not recoverable after. Even a child who is encephalopathic at 12 and bad at school, who gets the closure and improve, maybe he's only at 80% of what he would have been if he had no shunt for the first years of his life. And then finalize the discussion. Prenatal diagnosis and neonatal assessment is probably one of the key in the future. When we find a type 2, an early closure, like Stephanie proposed, through the umbilical vein would be possible if we have the prenatal diagnosis, and it's probably the easiest. If we are right, the type 2 is going into a type 1 by thrombose of the portal vein. What we could do if we pick the child when he's 2 months, 3 months, and the system, the intrahepatic system is still recoverable, we could propose a shunt reduction, mimic the model the nature gave me when I did the Mesorex. Or for those who are keen to do it, doing a very early Mesorex bypass. I mean, at 3 months of age, it is possible to do a Mesorex bypass if you have the same situation that I described. Another way would be to reduce the shunt in order to create portal hypertension, the cavernoma, maintain the intrahepatic portal system, and do the Mesorex later. So these are hypotheses, ideas. Now you do what you want with it. Thank you.
Thank you, Professor Deville, for this very interesting presentation. It's my pleasure to introduce the next speaker, Dr. Mara from Milano. He will talk about complication of closure and their management.